actually one big topic, which we actually have divided into two, just for the sake of making it more, maybe making it more lively, like we could call it. Like, and Ajit Krishnan has presented an exhaustive idea about how to assess a sick child, and also how to stabilize the sick child with shock. And another very important part to be managed in a sick child is the respiratory distress and failure, and that's what I am going to deal with now. After Ajit Krishnan's talk on recognition and stabilization of a sick child, we'll have a look at this video of the child. Okay. Obviously, a sick child. Sick means maybe obviously a life-threatening illness, and your initial impression itself would be a life-threatening illness requiring immediate intervention, like in the form of starting oxygen, and also proceeding to your further assessment and deciding whether any other intervention is needed or not. And in the next 30 minutes or so, what I am going to discuss will be, I mean, maybe fairly very familiar topic for the pediatricians in this group who are dealing with emergencies. But since this happens to be a mixture of all general practitioners also, I mean, this may look quite basic for some of the doctors who work in big hospitals, but I try to maybe discuss everything. I mean, the basic things regarding oxygen therapy in this. We'll discuss the adjuncts used in the management of respiratory insufficiency in children, and also the oxygen therapy, and also in the context of severe COVID-19 infection, the principles of respiratory support also we'll discuss. And as you know, there are a lot of peculiarities as far as the anatomy of the pediatric airway is concerned, which make children more susceptible to have difficulties. Airway obstruction is more in them. They have a lot of anatomic abnormalities you can see here. And one of the initial steps, like Dr. Ajit Krishnan mentioned, ABCDE. A is airway. The most important part would be to maintain airway, and he also showed how you can do some maneuvers like head tilt, chin lift maneuver to keep the airway open. And also, it's also important that you need to look for any other problem that is actually obstructing the airway, like secretions, which may need to be relieved by suctioning. And this is an oropharyngeal airway, which can be used in children who are unconscious, not in semi-conscious or conscious children. And this may sometimes help you to have a patent airway in an unconscious child. You know what happens when somebody becomes unconscious? The tongue falls backward and it obstructs the airway. The pharyngeal muscles lose their tone. So there is an obstruction to the airway, which can, to a certain extent, relieved by an oral airway, and also the maneuvers like head tilt, chin lift maneuver, or a jaw thrust maneuver, like what Dr. Ajit Krishnan mentioned. And it's important that you actually select the proper size of the oropharyngeal airway. It's there in the picture there. It's actually measurement from the mouth, the level of the incisor teeth, to the angle of the mandible. So if you choose a very small airway, oral airway, what will happen is that it can sometimes push the tongue further backward into the airway, causing further obstruction. Or if you use a bigger one, again, that the airway itself can, this oropharyngeal airway itself can block the airway. So it's very important, vital, that you choose the correct size of the airway. And another important point is that many of these children have secretions, sometimes vomitous, sometimes bleed, sometimes food particles may be there obstructing the airway, and it's important that you suction these out. There are certain points, like it's ideal that you have a wall suction in your hospital. It may not be there in all the peripheral hospitals. You can use a portable suction also. And something that is not usually looked at is the suction pressure that is used. It is -80 to -120, around 100 is the centimeter of water is the recommended pressure. If you use too much pressure, means it can sometimes be harmful to the mucosa. That's very important. And if you use a suction apparatus which has just less than -80 also, it may not be sometimes effective. Like. And the type of catheter that you use also, thin flexible catheters are there which we use for actually used for endotracheal tube suctioning or suctioning of thin secretions. Thin flexible tubes may be all that is needed. But then rigid catheters are also very important to be kept in the crash cart. I hope all our hospitals have crash carts now, because very important that you are prepared for the emergency. Like, so one of the very important adjunct that needs to be there in the crash cart is a rigid yank over suction catheter, because when you actually look for a rigid catheter, when the actual emergency comes, the child comes with seizures, having a vomiting and a lot of food particles inside the mouth, and you are having only a small flexible thin catheter, means it's not going to be effective. So very important that rigid catheters are also kept in the crash cart. And in the crash cart, it's a good idea always to have a checklist, and which is actually checked or I mean every day by the resident or somebody who is in charge, the nurse, and signed, so that you can be sure that everything is there. Like, it's not just the suction catheter I'm talking about, it's all the other equipments that we'll be talking about in the management of a sick child. And next important question that arises is when to start oxygen. Like, we saw this child now. Obviously, we would start oxygen in that child who was having severe distress, was having head bobbing, was having a grunt, you might have heard that, and obviously increased severe chest retractions also. That itself is an indication to start an oxygen. You need not wait for the pulse oximetry reading to start oxygen in that child. But pulse oximetry, if it is available, it's good. And indication would be the pulse oximetry reading. It's 92%, less than 92%. Some authorities mentioned 90% also. So 90 to 92% is the cutoff, below which you would start oxygen. And importance of pulse oximetry, I have mentioned there in the second sentence there, that in 30% of the cases, hypoxemia may be missed sometimes if you only look at the clinical signs alone. Like, for example, subcostal retractions, increased vacuum breathing, or may not be there, still the child could be having hypoxemia, especially in the COVID-19 context. We have heard of adults having happy hypoxia, but they are happy, they're walking about, still not having any breathing difficulty, but if you check the pulse oximeter reading, it is low. Like, so that could be there sometimes. So 30% of the cases, you may sometimes miss hypoxemia if you are not using a pulse oximeter, especially in COVID. In fact, we had one child recently with global developmental delay, COVID positive, had pneumonia. But then there was nothing to suggest a respiratory problem looking at the child. Like, occasional cough was there. That is the only respiratory complaint the child had. But fast breathing was not there. Low chest indrawing was not there. No signs of respiratory distress as such, but the pulse oximetry saturation rating was 88. So it's important that you use pulse oximeter to assess hypoxemia. And the importance, I kept that 92% there as a cutoff, below which you would start oxygen. And you can see the shape of this oxygen hemoglobin dissociation curve, which is got actually a steep area, but after that there is a flat area also, the upper part. So the flat area, actually, it comes down at the point where the saturation is around 90%. So just below 90%, even a very small difference will make a big difference in the PaO2 in the x-axis. You can see that. That's the reason why they have put the cutoff at 90%. So you keep this hemoglobin saturation above 90% always. Any child who has a saturation that is less than 90% needs oxygen. And suppose this pulse oximetry is not available, any sick child for that, you need to start oxygen. One simple thing to remember is in your triangle there, Dr. Ajit Krishnan mentioned the pediatric assessment triangle in your initial impression. Any two parameters abnormal, appearance, breathing, color, he mentioned. So any two abnormal means you start oxygen. That's one thing. And all these things like central cyanosis, nasal flaring, obviously we would start oxygen. The child is not able to drink or feed. That's one of the danger signs, that grunting is there. And the child had grunting, depressed mental status, severe chest indrawing, head nodding. And so in the triangle, any two are there means you start oxygen. And what type of oxygen to give? What device you will use to deliver oxygen? So I think it's a good idea. Remember, there are two major. I mean, it can be classified like a low flow system and a high flow system. Low flow system means the flow rates are lower than the patient's inspiratory flow rate. So the patient is taking inspiratory flow is there, peak inspiratory flow is there. If your oxygen flow is less than that, what will happen? The room air also will be entrained. So they will give a lower FiO2, that is lower fraction of inspired oxygen, and it's variable, like it can be anywhere between 22 and 60%. Whereas a high flow system is a device where the flow rate actually exceeds the patient's peak inspiratory flow. And they deliver FiO2 that is more than 60%. So oxygen flow rate is high, and the flow rate has to be at least more than 10 liter per minute. You can actually adjust it. We will discuss the devices where you can give high flow oxygen, and also devices where low flow system, I mean oxygen can be given. So whenever the child has a severe respiratory distress, it's always a good idea to start use a high flow system. So low flow devices are examples we all know: nasal prongs or cannula, nasopharyngeal cannula, something which we don't routinely use, and a simple oxygen mask, Hudson mask. You know that. The high flow systems devices are non-rebreathing mask, oxygen hood, Venturi mask, again not very commonly used, and the high flow nasal cannula. We'll be discussing some of these in the next few slides. And this is the commonest method of oxygen administration that we use: nasal prongs or a cannula. And as we mentioned initially, it delivers an FiO2 of 22 to 60% depending on the flow rate, and the flow rate varies between 0.5 and 4 liter per minute. Because in a young infant, we would start maybe with 0.5 to 1 liter per minute. In an older child, we might start more than that, but not more than 4 to 6 liter per minute. So generally up to 4 liter per minute. And in young infants, you know, the inspiratory flow rate is less. So naturally it will provide more FiO2. And if you use too much flow, like more than 6 liter per minute in a nasal cannula or nasal prong, what will happen? It will cause drying of the nasal mucosa, can cause bleeding also. So always use flow rate less than 6 liter per minute in a nasal cannula or a nasal prong, and especially in infants, use a lower flow rate. Simple mask, Hudson mask, we call it. The flow rate has to be around 6 to 10 liter per minute, and the FiO2 that is provided is 35 to 60%. It entrains, I mean, room air is also entrained when the child breathes, and that's the reason why it's not 100%. And next one is non-rebreathing mask. All of us know about this. We routinely use it, all of us, like in all the centers now. FiO2 to the tune of 80 to 95%. It has got some valves, like there's a reservoir also. There is a reservoir, and there is a valve that will allow oxygen to flow from the reservoir into the mask, whereas the expired air will not go into the reservoir. That is one mask. Another mask is there on the mask itself, which will allow the expired air from the baby to go out, whereas the room air will not enter into. And very important that you have a good seal of the mask to keep it the FiO2 80 to 95%. And oxygen hood, we all know, we have seen babies, newborn babies, and also young infants, because it delivers high oxygen. It's a high flow system. The flow has to be more than 10 liter per minute. Almost 80 to 90% FiO2 is delivered with this. The more important thing is that you must keep the flow rate about 10 liter per minute. Otherwise, what will happen? Rebreathing of expired air, carbon dioxide will be rebreathed again and again. So that is important. It's important that the flow rate has to be more than 10 liter per minute in an oxygen hood. Venturi masks are not commonly used in many of our hospitals. It actually works on the principle of the Bernoulli's principle, controlled and graded flow. There are varying, the aperture is different for all those color-coded masks. I think it's only, we are not using it routinely. It provides a FiO2 of 25 to 60%. And I'm sure many of you are using it in your hospitals. In fact, the WHO recommends this, like the poor man's CPAP, indigenous CPAP. We can easily make it in our hospital also. All that is required is actually a nasal prong, and also an underwater seal, and also a T-tube, or something which you can use to keep that. I'll show you one more picture there. Indigenous CPAP is there. Underwater seal, you just put that expiratory limb inside the water, and the depth of the tube inside the water actually will be equal to, you actually measure the centimeter of tube that is inside the water, and that much is the PEEP that is provided. You know why we give PEEP for a child having a parenchymal lung problem? Because the PEEP actually keeps that peak and expiratory pressure, which will actually keep the alveoli open. Okay. This is a little more sophisticated type of CPAP machine, where from the oxygen source, you can see that it is there's an oxygen source with a blender there, because oxygen source means it is 100% oxygen. Now, if there is a blender with air also, you can provide oxygen concentration that is required for the child, like between 21% and 100%. So blender ideal is having a blender. From the blender, this oxygen comes, and then the expired air, the expiratory limb of the tube actually goes into the water, and you can see the bubbles coming from the bottle. And the depth of the expiratory limb actually tells you how much is the PEEP that is given to the baby. And the expiratory pressure, if that PEEP is maintained, means we can keep the alveoli open, and that will actually decrease the work of breathing, as well as that will increase the oxygen status also. So hypoxemia is corrected. And commercially available CPAP machines are also available, like this one, where there is a blender, there is a heating system also for this. So it's actually heated humidified air that is provided, and again you can see the underwater seal there, which will provide the PEEP. That's a bubble CPAP again, and the same thing, increases the functional vesicle capacity, improves compliance and oxygenation. I have discussed that the alveoli which are collapsed actually are kept open end of expiration because of this pressure, and it can maintain and explain the collapsed airways also. That's why it could be sometimes useful in children with asthma also, and it reduces work of breathing and oxygen consumption. The tidal volume is increased. So bubble CPAP is one thing that you can resort to if the child is not responding to your initial nasal cannula or non-rebreathing mask. If you provide some PEEP in the form of a bubble CPAP, it can sometimes cause increasing oxygen saturation. So increased work of breathing with saturation not maintained, bronchial asthma, lung parenchymal disease like pneumonia, and also when you wean the child off from invasive ventilation. If the child is apneic and if the child is impending cardiovascular collapse, you would not use this. Obviously, that child needs maybe an advanced airway like an endotracheal tube. And very important that you ensure an oxygen flow of at least 5 to 8 liters per minute. And see that there is a constant bubbling in the bottle. Some of the complications that can rarely happen are air leaks because of the pressure that you are providing. Rarely pneumothorax can develop, aspiration of feeds can be there, abdominal distension can be there, but these are not very common. We use this routinely for our children with bronchiolitis, and especially in June, July, after rain, we are expecting many cases of bronchiolitis, and bubble CPAP indigenous, that is actually made low cost, bubble CPAP is extremely useful. And this is another device called a flow inflating bag, the Bain circuit and Jackson-Rees circuit you may have heard of. This is Jackson-Rees circuit. This actually is the compressed air is coming, and that it is actually the flow that inflates the bag, and which will provide oxygen. You can have a PEEP also on the left side. You can see the expiratory limb there, a PEEP, and adjusting the PEEP valve, you can adjust the PEEP also. We are not using it routinely, but then it used to be available in our hospital for some time, and now it's unfortunately not available. It's a very good device to deliver oxygen. So this is high flow nasal cannula. This used to be a luxury for all of us in government setup till COVID started, but then after that, a lot of machines have come now. I'm sure it is there in even peripheral hospitals now. High flow is extremely useful, and it's a high flow device that is very well tolerated by children and extremely useful also in the conditions we'll be discussing about that. It actually creates an oxygen reservoir in the anatomical airways, allowing high FiO2 delivery. The flow is very high, so high FiO2 is delivered. It increases alveolar ventilation, and heated humidified air, oxygen, air mixture is what is given. So it actually prevents drying of airway epithelium, and because of the flow, it actually improves the mucus clearance also, and extremely well tolerated by patients. And there is nasal trauma is much less compared to other oxygen delivery devices. And bronchiolitis, it's very useful. Pneumonia, congestive cardiac failure, and also when you wean the child off from mechanical ventilation. But then if the nasal passage is blocked due to some reason, any reason, anatomical reason, like for example, a corneal atresia, or if there is a trauma or surgery there in that area, which has actually caused a blockage of the nasal passages, it cannot be used. And after that, another method of, that we can maybe resort to is a non-invasive ventilation. Before we actually proceed to intubation, this is another approach. Like non-invasive ventilation, there are many types. You might have heard of BiPAP, or you might have heard of actual conventional ventilator itself providing non-invasive ventilation, or there are dedicated NIV machines also. And in fact, there are two levels. That the inspiratory pressure is set, can be set, and expiratory pressure also can be set. And this pressure gradient actually results in air movement. We are not actually putting in a tube into the into the trachea. So it's a non-invasive. Only problem is that you need to have an interface, like a mask that is tight fitting. So that tight fitting mask itself could be a cause for problems like the mask itself causing injury to the face and other places. But then if there is a tight seal, it is useful in providing adequate flow. And also CPAP. Peak and expiratory pressure, PEEP. So suppose this non-invasive ventilation also fails, you may have to resort to endotracheal intubation. That's the last resort. Right? So endotracheal intubation to provide adequate airway, because airway is blocked means you may have to sometimes intervene. Like for example, a child having severe upper airway obstruction, like epiglottitis, which fortunately is not very common nowadays, or a very severe group where you may have to sometimes intubate to protect the airway in a person who is unconscious. GCS, a Glasgow Coma scale less than 8. They cannot protect their airway. Cough reflex is not there. So aspiration is most possible. You may have to intubate. Or obviously, respiratory failure, like the one which we saw, the first child was obviously in an advanced state of respiratory failure. They will need endotracheal intubation. And you need to select the appropriate ET tube size. And in the COVID situation, it is recommended that you use only cuffed endotracheal tubes. Fortunately, cuffed endotracheal tubes are available in all sizes now. And that's how you select the ET tube size. It is 8 divided by 4 plus 4. For example, if it is a 4-year-old child, it is 5. 5 is the endotracheal tube size. So uncuffed tube. Cuffed tube, it will be one size less than that. That cuffed tube will be 8 by 4 plus 3. And it's always a good idea that you keep tubes which are one size above and below also ready in case you may, because children sometimes can come in different sizes, like they're you may have to use a lesser, because just based on age it may not be correct sometimes all the time. And cuffed endotracheal tube, you again, if you have a cuff pressure monitoring manometer, a pump is there. We have that fortunately in our ICU. You just keep the cuff pressure at 20 to 25 centimeter water. And ET tube insertion depth is internal. It's easy to remember. Internal diameter multiplied by 3. For example, if it is a 4 size ET tube, it is 4 into 3, 12 centimeter depth of insertion from the incisors. So you can, how much you should insert. And during this severe COVID-19 infection, the child comes with severe COVID-19 infection. What are the differences? Like clinical presentation, of COVID-19 pneumonia is non-specific. It can mimic any other illness. Like for example, it could be an adenovirus pneumonia, it could be an RSV pneumonia, or a viral influenza, or even sometimes bacterial pneumonia. We don't know. That's the reason why any child who presents with a respiratory problem, you consider COVID as the first possibility during this season and treat accordingly. When long back when we were students, the late 1980s, there is a time when HIV was there. Like I had just come, like there was no treatment for HIV. So once you get HIV, means that is the end of everything. Like that used to be the case So everybody was scared, like any person coming to the emergency could be HIV positive. That is the situation those days. And it is something like that what's happening now, like COVID-19 also. Any child respiratory illness could be COVID-19. And but then at the same time, you need to think of all other infections also, because there may be treatable other conditions like a bacterial infection also. It's very important. And the test that we do, rapid antigen test, could be false negative also. So it's always better that you take all the precautions, all the to prevent transmission. And the management of COVID pneumonia is similar to other infections. But only thing is that you need to follow strict precautions to reduce transmission. And oxygen therapy, all patients with respiratory distress or hypoxemia require oxygen, and your target is 94% and above saturation during resuscitation. You need to keep it above 94%. And when you start the child on oxygen, you keep it between 92 and 96% saturation. So this is how you escalate your oxygen therapy from a nasal cannula to a Hudson mask to a non-rebreathing mask, and use high flow nasal cannula, and an NIV if it is available, and or finally the conventional ventilator. So HFNC in COVID, that's preferable over NIV if first line oxygen delivery devices fail. So suppose you have NIV and HFNC is much better tolerated. But if you have HFNC, you use it, and you use the minimum flow. All these interventions carry the risk of generating a lot of aerosol. That is a big risk to all the healthcare personnel around. That have to be very careful about. So that's the reason why we are isolating these children. It's not just droplet infection. Aerosols can be generated. And unlike other situations where you might use a 2 liter per kilogram per minute flow initially itself, you use a lower flow rate like 0.5 liter per kilogram per minute HFNC flow initially. Then you gradually increase to 2 liter per kilogram per minute. In fact, for the first 10 kg, what is recommended is use 2 liter per kg per minute initially, and then for the next, it is 0.5 liter per kilogram usually. But for COVID, you start with 0.5 liter per kilogram per minute initially, then increase to 2 liter per kilogram per minute. And the target oxygen saturation is 92 to 96%. And very important that you should not keep on continuing to give this HFNC or NIV support and wait for response. The child is not responding after 1 to 2 hours, means always better that you escalate your intervention to endotracheal intubation. Otherwise, you might lose the child. And as I mentioned, aerosols are a big problem. Very important that all healthcare personnel wear proper PPE, and you switch on the machine only after fixing the nasal cannula, because before that you switch on the machine, and then after that you put, then again the child might sometimes start becoming panicky. That can result in again generation of a lot of aerosol. And if you put a 3-layer mask over the nasal cannula, over the cannula, it might sometimes prevent some aerosol from getting disseminated. And or instead of a mask, you can sometimes keep an oxygen hood also in small infants. Another modality is a non-invasive ventilation, which we discussed already. But then the problem is that there is a very high failure rate, and it's better that you can use NIV. You can use, if you are using it, it's better that you use a conventional ventilator where there is an NIV option. So for there are 2 types of masks available. Non-vented and vented. So in fact, the vented mask is for the expiratory air to go out. So, but the vented, non-vented mask usually has 2 tubes. So dual lumen non-vented masks are the preferable ones, which are the ones which are used along with the conventional ventilator. So those are the ones. Otherwise, if you use a BiPAP with a single lumen with a vented mask, means all the aerosols may come out, and that can be a real risk for all the healthcare personnel and others in the room. And in the exhalation port, you can use a viral filter. So most of the HME filters that come that are there in our ICUs are viral filters also. It will be written there on the HME filter. You know what HME filter is? HME filter is a heat moisture exchange filter, which can be used instead of a humidifier in a ventilator. So that HME filter can be used as a viral filter also, provided the company tells you that it can be used. Like, so viral filter bar HME, it will be written there. Like, so this viral filter can be kept at the exhalation port. That will prevent, risk to other people in the room to a certain extent. And PEEP, you use the lowest PEEP because usually high PEEP is not required initially in COVID pneumonia. We'll come to that afterwards. And you can, very important that you don't, I have already mentioned that NIV, there is a very high failure rate, and don't wait for more than 1 or 2 hours with NIV before you actually resort to endotracheal intubation. And you can maybe use an aerosol box with ports covered by masks also to prevent aerosol. And but as a last resort, we may have to resort to mechanical ventilation. So despite non-invasive ventilation or despite your HFNC, the saturation continues to be less than 90%, or the PaO2 divided by FiO2 ratio. That is, if PF, we call it PF ratio, if it is less than 150 despite NIV. Severe respiratory distress is there in a child who is already on NIV. The child is breathing, lot of vacuum breathing is there, and large tidal volumes like more than 9.5 ml per kilogram is generated on NIV. Child is in refractory shock, or a child who has a Glasgow coma scale less than 8. They're all indications to intubate the child. So if you delay intubation, sometimes we may lose the child. So don't keep waiting for more than 1 or 2 hours on NIV in a sick child. And endotracheal intubation is even more risky in COVID because, again, that can create a lot of aerosols and that can potentially infect the healthcare personnel. There's nothing called an emergency. If in a pandemic, like suppose a child is in cardiac arrest also, you would rather wear the PPE and then go and start CPR, because you have to save yourself. We have seen in flights and all that, when there is a problem with oxygenation, that those masks come down, and then the the flight attendant will tell you that you have to wear the mask first, and then only provide mask to the person sitting next to you, because unless you are saved, you will not be able to save the other people. Right? So it's very important that you save yourself first. It's not selfishness. Right? And minimum number of people should be there in the room where you intubate. Only 3. One person who is actually doing the intubation, one assistant, and the nurse to give you medications and all that. If you have a negative pressure room, it's ideal. And we discussed the importance of crash cart, keeping everything ready. Preparedness, very important, so that you will not have a problem in an emergency. And when you decide to intubate a child having a suspected or proven COVID infection, rapid sequence intubation should be done with proper paralysis, and keep all the rapid sequence intubation drugs ready in the crash cart. I think discussing about RSI is beyond the scope of this class, so I will not be discussing that. And very important that you be ready with the plan B in case you are not able to intubate. It is very important that the most experienced person in the team intubates the child, because the senior most person maybe. Otherwise, multiple intubation attempts, each intubation attempt will increase the risk of aerosol. So suppose your intubation attempts fail, what will you do? You can use an airway, another advanced airway like a laryngeal mask airway, or another supraglottic device like an iGel. So you have to have a plan B always in a child with COVID infection. Or you have to have the number of, inform the anesthetist in advance so that you can get the help of anesthetist also. All that. And this I already mentioned, there is rapid sequence intubation. You ensure that full neuromuscular block is there before attempting intubation. You can use an aerosol box or a transparent sheet. I'll show you one picture in the next slide to minimize the aerosol dispersal. And this I mentioned, the most experienced person has to intubate. And we sometimes pre-oxygenate the child before intubation using bag and mask. But if you use a bag and mask, again, the chance of aerosol generation is more. It is better that you use a non-rebreathing mask if it is possible to maintain oxygenation with that, or a Jackson Reese circuit, which can provide some PEEP again, that will not cause as much aerosol as a bag and mask would do. And if at all you need to use a bag and mask ventilation, again, we use a viral filter HME, which I was discussing about, between the mask and the ambu bag. I'll show you one picture there. And if you use a 2% bagging, that will be much more effective than the 1% with the bagging using the EC technique. And some more precautions, because it's very important during our COVID season in case you decide to intubate the child. If video laryngoscope is available, you use that. It used to be a dream for all of us in government setups until about 2-3 years back. But then thanks to COVID, we have got many video laryngoscopes now in our hospital. Connect ventilator tubing with viral HME filter that we already discussed. At the exhalation port, you connect the, you keep one viral filter. I told you the HME filter that comes has a viral filter also now. So most of them. So you can use an HME filter with a viral filtering mechanism. And before you actually intubate the child, it's better that you keep the ventilator with all the settings ready. Because once you intubate means again there is a risk of aerosol generation. So immediately after intubation you need to connect the child to the ventilator. So everything has to be ready, kept ready like. And the closed suction is very useful in preventing again aerosol generation, and as well as you disconnect frequently means it's a big problem. Like it can sometimes result in loss of PEEP and the child might further worsen. So it's better that you don't disconnect the child from the ventilator frequently. Like so, if you use a inline closed suction, it's always useful. And this HME filter also expiration limb I told you connect it before you actually do the intubation. And inflate cuff immediately. The endotracheal tube cuff needs to be inflated immediately post intubation, because the peritubular leak again could sometimes be a health hazard. And once you connect, actually put the tube in, what we usually do is you bag and then auscultate and see if the tube is in position. In COVID-19, it's better that you avoid that, because again that's a risk for all others. So what we do is you just put in the tube and then see after bagging, just you don't auscultate and all that. You put in the tube and immediately connect the child to the ventilator and see if there is a chest rise that is happening. If there is an ETCO2 that is connected to the side port, that you can see the ETCO2 and see if the tube is in position. And afterwards, you can take a chest X-ray. But sometimes it may not be possible to confirm with all this. You may have to do bagging, but then it's better that you avoid it. And the aerosol generated will settle in 20 minutes, and you clean the room after 20 minutes once after the procedure. And after the intubation, you put in the nasogastric tube. And in case you need to disconnect the child from the ventilator due to some reason, like for example, the child needs to be transported to a CT room, then you clamp the tube beforehand so that the tube is not kept open when you disconnect. So this I have taken from Indian Pediatrics. There you can see that first arrow, an HME filter that is kept between the mask and the bag when you actually manually bag the child. And in the other picture, they have used a plastic sheet, transparent sheet, that will again avoid aerosols getting disseminated inside the room. And the video laryngoscope being used, and also you can see the plastic sheet being used to avoid aerosol dispersal. And the ventilator settings, I don't think that it is required for this audience here. But then, like only one point is, if you are ventilating initially, you don't treat it as ARDS, like the conventional ARDS. The conventional ARDS means they usually require high PEEP and low volume. But then we have heard of two types of lung in adult COVID, like L-type lung and H-type lung. L-type is a low elastance lung where the compliance is actually good. It's not like ARDS. They have hypoxemia, compliance is good. Actually, the problem is there with the interstitium. So such children may not need a high PEEP to begin with itself. So you can start with the PEEP of the usual PEEP that we keep like 5 to 6 and then titrate. And tidal volume, generally it's better that you keep it at 6 ml per kilogram, but you may sometimes have to increase the tidal volume also. What is conventionally taught in ARDS treatment is you keep a low tidal volume strategy, but initial part of the COVID pneumonia, they don't behave like the conventional ARDS. So that's it. So I think we can have more discussion on this during another ventilation class. And goals of ventilation is to keep the SpO2 between 90 and 94, and plateau pressure less than 28, and the driving pressure less than 15. I think we will not be discussing the details here. And proning, it is not possible in many of the centers in our place, because many centers have very low experience in proning, and inexperienced people doing this proning can sometimes result in more chance of personnel getting infected. And if at all you are doing proning, keep it for 16 to 18 hours if it's possible. Okay. Another important point is that you avoid positive fluid balance in the children if possible. Like positive fluid balance, like in all other sick children, it is harmful in ARDS. So a fluid restriction strategy is very important. I think that was the last slide. Thank you very much.
In multi-parameter or pulse oximeter, separate pediatric probes needed, or can be used as in adults?
Small pediatric probes are available for infants. Infant probe is there, pediatric probe is there, adult probe is also there. So you can ask the company people to provide that.
How can we calculate flow rate while using simple mass? That is the next question, or nasal prongs.
Yeah, flow rate, you can see the oxygen source itself. We have a flow meter. You can just see the flow rate there. You can adjust the flow rate also.
Yes. I'm Dr. JP from ICH Kottayam. So you said about two types of lung. So what strategy you generally go with 6 ml per kg, and you said the peak plateau pressure is less, should be maintained around 28. Is it always possible to go like that in cases you have seen?
In fact, we have not seen many cases with severe COVID pneumonia. We only had around 6 or 7 cases with severe COVID pneumonia so far, and all of them had some kind of comorbidities. And we had, all these cases were behaving like a typical ARDS. So they required a very high PEEP, and the usual ARDS kind of management was given. It's not the L type. I have not seen any. I am not able to differentiate between L type and H type and all that, like what they say in adults and children. Maybe we have not seen many cases. That's the reason.
I have one general question. While giving oxygen through hood for newborns with respiratory distress, whether we should give a high oxygen level, liters per minute? How much to give for mild respiratory distress?
For oxygen hood, the problem is that if the flow is not more than 10 liters per minute, what will happen is that the child's expired air will be rebreathed. That's the problem. Rebreathing of expired air. So you need to have a good flow so that the carbon dioxide is washed out. So 10 liters per minute should be there.
Usually we keep lower liters per minute.
In that case,
hence even with the mild respiratory distress also, we have to keep more than 8 to 10 liters.
Oxygen, there's a problem with oxygen food. It will give 80-90%, almost 90% FiO2. Provide 90%.
Okay. Thank you.
Yes, I'm Dr. JP. So you're using the ordinary HME filter at the expert report. You're using the ordinary.
നമ്മൾ യൂസ് ചെയ്യുന്നത് HME ഫിൽറ്ററിന്റെ മേലെ വൈറൽ ഫിൽറ്റർ അങ്ങനെ എഴുതിയിട്ടുണ്ട്. അങ്ങനെയാണെങ്കിൽ അത് യൂസ് ചെയ്യാം. ഇപ്പോൾ കിട്ടുന്ന HME ഫിൽറ്റർ നമ്മൾ KMSCL കിട്ടുന്നതാണെന്ന് തോന്നുന്നു. അതിലെല്ലാം കുറെ എല്ലാം ഇങ്ങനെ വൈറൽ ഫിൽറ്റർ എന്നും കൂടെ മെൻഷൻ ചെയ്തിട്ടുണ്ട് സ്പെസിഫിക്കലി. ദാറ്റ് ക്യാൻ ബി യൂസ്ഡ്.
Okay.
പിന്നെ അത് യു നീഡ് ടു ആസ്ക് ഫോർ എ നിയോനേറ്റൽ ഓർ എ പീഡിയാട്രിക് HME ഫിൽറ്റർ. Adult HME filter വെച്ച് കഴിഞ്ഞാൽ that will cause a lot of resistance in the circuit. അത് ഒരു പ്രോബ്ലം ആണ്. അപ്പോൾ
so there is a question, can we use A/AD or O2 calculation to decide on early intubation and invasive?
No, that is not recommended for routine use.
Sir, what to do with the isolated tachycardia? Heart rate is 136 per minute with all other parameters normal, BP, temperature, respiratory, all in normal in a COVID positive child.
Isolated tachycardia.
Isolated tachycardia എന്ന് പറഞ്ഞാൽ അത് എന്തെങ്കിലും മേ ബി ഇപ്പൊ പറഞ്ഞ പോലെ നമ്മളെ കണ്ടക്ഷൻ ബ്ലോക്കുകളൊക്കെ ചിലപ്പോൾ മിസ്കിലൊക്കെ ഈ പറഞ്ഞ പോലെ കണ്ടക്ഷൻ ബ്ലോക്ക് ഒക്കെ ചിലതിൽ വരാം. അല്ലെങ്കിൽ ടാക്കിക്കാർഡിയ വരുന്ന കാര്യം എനിക്കറിയില്ല. യു ഷുഡ് ഹാവ് സം അതർ റീസൺ ഫോർ ദ ടാക്കിക്കാർഡിയ. പറഞ്ഞ പോലെ ഫീവറോ വേറെ എന്തെങ്കിലും ഡ്രഗ്സിൻ്റെതോ എന്തെങ്കിലും കൊണ്ടുള്ള ഒരു ടാക്കിക്കാർഡിയ വരാം. അല്ലാതെ ഒരു എല്ലാം നോർമൽ ആയിട്ടൊരു കാർഡിയോവാസ്കുലർ ഡിസ്ഫങ്ഷൻ എന്ന് പറയാൻ പറ്റില്ല. ഏതർ ഇറ്റ് ക്യാൻ ബി അരിത്തിമിയയുടെ ഒരു പാർട്ടായിട്ടും ഇത്രയും ഒരു ചെറിയ യു ഹാവ് ടു ലുക്ക് അറ്റ് ദ ഇസിജി ടു സേ കണ്ടക്ഷൻ ബ്ലോക്ക് തന്നെ ബ്രാഡിക്കാർഡിയ ഒക്കെ വരാം, കണ്ടക്ഷൻ ബ്ലോക്ക് വരാം, പിയർ ആൻഡ് റോൾ ബ്ലോക്ക് അങ്ങനെയൊക്കെ സാധനങ്ങളൊക്കെ വരാം. പിന്നെ ഈ ടാക്കിക്കാർഡിയ ഇസ് നോട്ട് 136. അപ്പോൾ ഒരു ചിലപ്പം ഏതെങ്കിലും അതർ കണ്ടീഷൻസ് ആയിരിക്കും, സൈനസ് ടാക്കിക്കാർഡിയ, ഫീവറോ വേറെ ഏതെങ്കിലും വൈറൽ ഇൻഫെക്ഷന്റെ ഭാഗമായിട്ടോ ട്രാക്കിന്റെ വല്ലതും ആയിരിക്കും.
IGL is a supraglottic device. It's costly, but it is just like LMA, laryngeal mask. It can be very easily put. Not much expertise is needed. The different sizes are available for age, based on age.
Actually, which vaccine is better, Sputnik or Covishield in children above 18 years? If so, why? A general question. Usually, what Aravind says is, whichever vaccine you get is the best.
ഏതെടുത്താലും അത് തന്നെ വീണ്ടും എടുക്കണം. അതാണ് അതിന്റെ പ്രധാനം. ഒന്നെടുത്താല് സ്പുട്നിക്കിൽ എന്ന് പറഞ്ഞാൽ 2 അഡിനോ വൈറസിന്റെ 2 സ്ട്രെയിൻ ആണെന്ന് തോന്നുന്നു. അപ്പം എന്തോ അത് ഒരെണ്ണം എടുത്തല്ല അതിന്റെ രണ്ടാമത്തെ ഡോസും അത് തന്നെ എടുക്കണം. കോവിഷീൽഡ് ആയാലും ഏത് വാക്സിൻ ആയാലും അതുപോലെ തന്നെ.
Next is child with arrhythmia, conduction block comes in a peripheral center. How to manage the child till they reach a tertiary center for definitive management?
Child with
arrhythmia, sir.
Arrhythmia.
Peripheral center lo vannu definitive management center il ettunnathu vare engane manage cheyanam?
ഡിപ്പെൻസ് ഓൺ അർത്തിമിയ എന്താണെന്നുള്ളത് നോക്കിയിട്ട് അതിനനുസരിച്ചുള്ള ട്രീറ്റ്മെന്റ് ഉണ്ട്. ഇപ്പം നമ്മുടെ പാഴ്സലായാലും ഇപ്പൊ സൂപ്രാവെൻട്രിക്കുലർ ടാക്കിക്കാർഡിയ നമുക്ക് കൊടുക്കാൻ പറ്റുന്നിടത്താണെങ്കിൽ കൊടുക്കാം. അല്ലെങ്കിൽ നമ്മൾ ഈ പറഞ്ഞതുപോലെ ഇപ്പൊ വേഗൽ മാനോവസ് ഉണ്ട്, അഡിനോസിൻ കൊടുക്കുന്നുണ്ട്. അപ്പൊ അതില്ലാന്നുണ്ടെങ്കിൽ നമുക്ക് സപ്പോർട്ട് ചെയ്താലേ ഇപ്പൊ അത് അർത്തിമിയ എന്ന് പറഞ്ഞാൽ അർത്തിമിയ കൺട്രോൾ ചെയ്യാതിരുന്നാല് അത് ശരിയാവില്ല. ബാക്കി നമ്മുടെ വേറെ സപ്പോർട്ട് കൊണ്ടൊന്നും അത് ശരിയാകത്തില്ല. ഡ്രഗ്സ് ഉണ്ട്, അതിന്റെ ഡ്രഗ്സ് അത് യൂസ് ചെയ്താലേ പറ്റത്തുള്ളൂ. അപ്പം ഡ്രഗ്സ് അല്ലെങ്കിൽ ഡിഫിബ്രിലേഷനോ വാട്ട് എവർ ഇറ്റ് ഈസ്, ഇഫ് ഇറ്റ് ഈസ് അർത്തിമിയ ഇറ്റ് ഹാസ് ടു ബി ഡെൽറ്റ് വിത്ത്. അപ്പൊ അതല്ലാതെ സ്റ്റെബിലൈസ് ചെയ്യാനായിട്ട് അർത്തിമിയ സ്റ്റെബിലൈസ് ചെയ്യാതിരുന്നാൽ കാർഡിയക് കൺട്രാക്ഷൻ കറക്റ്റ് ആയിട്ട് നടക്കത്തില്ലല്ലോ. അപ്പൊ അർത്തിമിയ സ്റ്റെബിലൈസ് ചെയ്യണം. പിന്നെ അല്ലാതെ ഈ പറഞ്ഞ പോലെ ബ്രാഡി അർത്തിമിയോ ടാക്കി അർത്തിമിയന്റെ വേറെ മാനേജ്മെന്റ് ഉണ്ടെങ്കിൽ അത് ചെയ്ത് ഇത് കൺട്രോൾ. പക്ഷെ അർത്തിമിയ ആണ് കോസെങ്കിൽ അത് കൺട്രോൾ ചെയ്താലേ പറ്റത്തുള്ളൂ. സെക്കൻഡറി കോസ് വല്ലതും ഉണ്ടെങ്കിൽ അത് ശരിയാക്കാം. ഈ പറഞ്ഞ പോലെ ദർ ഈസ് എനി സെക്കൻഡറി കോസ് ഫോർ ദ അർത്തിമിയ യു ക്യാൻ, ഇപ്പം വല്ല ഡ്രഗോ വേറെ എന്തെങ്കിലും ഇതൊക്കെ ആണെന്നുണ്ടെങ്കിൽ അതിനെ ചെയ്യാം. അല്ലെങ്കിൽ ഒരു ഇപ്പോൾ SBT വന്നാൽ SBT റിവേർട്ട് ചെയ്താലേ പറ്റത്തുള്ളൂ. അഡിനോസിനെ കൊടുക്കണം, അല്ലെങ്കിൽ ഇത് കാർഡിയോവർഷൻ ചെയ്യണം. അത് ചെയ്താലേ പറ്റൂ PT ആയാലും. പിന്നെ വേറെ ചിലതിന് ട്രീറ്റ്മെന്റ് ഉണ്ട്. ഇപ്പം അവളുടെ അട്രോപ്പിൻ അതുപോലത്തെ ട്രീറ്റ്മെന്റ് ഉണ്ട്. ഇപ്പം ബ്ലോക്ക് ഒക്കെ ആണെങ്കിൽ ഐസോപ്രനാലിൻ അങ്ങനെ ഇതൊക്കെ ട്രീറ്റ്മെന്റ് ഉണ്ട്. അതൊക്കെ നമുക്ക് കൊടുക്കാം. ഡിപ്പെൻസ് ഓൺ ദ അർത്തിമിയ.